Hi, everyone. Give it another minute. I still see people popping in from the waiting room. Okay, welcome. This is the 20th meeting of the House Bill 1477 Crisis Response Improvement Strategy Committee. I'm Jamie Strauss-Clark, your facilitator. Nice to see so many familiar names on the screen this afternoon. Before we get started with our meeting, I'm just going to run through my usual pre-meeting housekeeping items. So I'm going to ask that Chloe advance. Thank you, Chloe. Chloe's got two slides for you. They look very similar, but one is for our CRIS committee members and one is for our community members and guests. So starting with the slide for the CRIS committee members, if you could please keep your mics on mute unless you're speaking in the meeting. Advance, please. And if you can, if it's available to you, particularly during our discussions, if you could have your video cameras on, CRIS committee members, that just helps us interact better with each other. It's fine to keep them off during the more presentation parts of our agenda today, which I will walk through shortly, so you know when that's coming. Advance, please. We use the raise your hand function to raise our hands in meetings and indicate that we would like to speak or offer a question or comment. And to do that, you click on the reactions button, pops up a window, and then click on raise your hand. As I always say, if all else fails, you can just wave your hands and I will do my best to call on you in the order in which I've seen you raise your hand. Advance, please. CRIS committee members, you may use the chat to send me, Jamie Strauss-Clark, a chat question or comment. If you would like, if it's just for my information and you would not like me to read it out loud to the rest of the group, please indicate that at the beginning of your chat. Or if you'd prefer it not to be attributed to you, that's also okay, but please just let me know at the beginning of the chat message. Other chats I will just read out to the group, and that's just for CRIS committee members. Community members, I'll talk a little bit about you in just a moment. Please advance. If you'd like to see as many CRIS committee members on the screen as possible during our meeting, you can click on that speaker view button and switch to gallery view. All right, let's advance the slide. So this is a similar slide, but a little bit different for members of the public. So members of the public, if you could please keep your mics on mute for the meeting, except for when we are going to have a group discussion today with community members, and that would be an opportunity if you raise your hand to speak to turn your mics off. Similarly, if you can advance, Chloe, members of the public during the main part of the meeting when CRIS members are in the main room with us, if you could please keep your video cameras off, that just helps me see just the CRIS committee members on the screen and allows me to facilitate a little better with them, especially when we often have upwards of 80 to 90 people participating in this meeting. Later on, when we get to the part of the agenda where I'm facilitating a discussion with the community in the main room, that would be a great time to turn your video cameras on. Advance, please. Similar instructions for you. You can feel free to click on that speaker view button and change to gallery view to see more of the CRIS committee members on your screen. I think that covers it for those housekeeping items. I do want to note that we have two ASL interpreters today, Carol, who's currently doing the interpretation, and her partner, Amber, who will be switching off with Carol every 15 minutes throughout the meeting. And those folks will be pinned to your screen as they are interpreting. But again, if you switch to gallery view, if you don't need the ASL support, you can switch to gallery view and see more of the CRIS committee members. CRIS committee members, I also just want to remind you, when you're speaking today, if you wouldn't mind reintroducing yourself when you speak, that will help our community members and new CRIS committee members recognize who you are and get to know you better. And then finally, if you're experiencing any unstable internet today, a couple of tips: you can choose dial-in for the audio instead of internet. That sometimes works. Another alternative is to turn your video camera off. All right, I think that covers it. So Chloe, if you would not mind taking the slides down, I am going to invite our very own CRIS committee member, Linda Grant, CEO of Evergreen Recovery Centers, to offer words of welcome. Linda.
Hello, I'm sorry I was looking the other direction. My name's Linda Grant, as she said. I'm with the Evergreen Recovery Centers, and this is actually the 52nd year that I've worked in this field, and started in crisis with both a detox program in Ellensburg, Washington, which did not have a detox program, I'll explain later, and as a mental health professional that did commitments at that point. And so I'm always pleased and excited to see the changes that have taken place in our field over these years, and still always challenged by the things that I think we could do more of. And so I appreciate the opportunity to talk a little bit about my perspective. As many of the people in the alcohol drug field, I come with a variety of personal experiences in both mental health and alcohol and drug treatment. And one member of my family died on Skid Row on 2nd Avenue in Seattle. And another died at a high-end treatment center at that point in Monroe. So, all walks of life are represented by this disease. When we started, it was primarily alcoholism that we looked at, and drugs were fairly well contained. Nowadays, we look at the whole spectrum of substance use disorders. I think the history is helpful. In 1972, the state passed the Uniform Alcoholism and Intoxication Act because they felt that drunk tanks were not the right place for people to be brought when they were passed out on the streets, and that we needed to look at more humane and more helpful ways of interacting with persons with alcoholism. And so my first job was as a drug detox counselor in a city, Ellensburg, that had no detox, but the drunks were either taken to the drunk tank or they were taken to the hospital. If they went to the hospital, my job was to make them not seen or a bother and to see if I couldn't do something about them. One of our tools of the trade at that point, and I had a master's degree in counseling, so this was all a real different kind of experience for me, is I learned to carry a fifth in my car, because if they started going into DTs, why then you wanted to give them a little bit of alcohol to hold it off until they reached the destination. It was a very interesting time where incapacity was simply being on the street, laid out, and the police usually found you, and then somebody had to do something about them. Today, it's quite different, but the drunk tanks were at least full of persons who were not getting help. And so this is the evolution and really the origin of the alcohol and drug treatment field. It started with alcoholism, and about in the 1980s, they added drugs because we had been quite successful with what we were doing with alcoholics. And so in those days, we looked at incapacity as medical necessity. Nowadays, we have much more refined criteria with ASAM, the American Society of Addiction Medicine, and we're much more informed about how we do our services by the medical community and by ASAM. The first services in 1972 were called Alcohol Information and Referral Centers, and that was how I came to have that job in Kittitas County, having just graduated from graduate school there in counseling psychology. And our treatment centers consisted of a few detoxes here and there, a recovery house here and there. The closest recovery house to Ellensburg was up in Tonasket, so that was like a 4-hour drive with a drunk, and otherwise it would be about a 2-hour drive. And we had self-help groups. And so the first thing that I did when I started in the field was sit down with the people in AA and say, what do I do? How do I do this? What do I need to learn? And a lot of my mentors were people who had actually found recovery through using a self-help 12-step AA program. And so we really started from there to develop a profession. And my passion for detox has continued because I still see it as the front line of people in crisis. And they are the people who are really in three different conditions. Either they are afraid of withdrawing because they have run out of drugs and they don't know what to do. And they really don't want recovery. They just don't want the pain and the discomfort of withdrawal, which for some of the drugs is really quite miserable. The drugs that you can die from are still benzodiazepines and alcohol. You do not die from opioid withdrawal, but you wish you were dead. It's a very, very uncomfortable withdrawal. And one of the reasons that we use medication so much is to ease that process. And they come with mixed emotions. Some actually are at that place where you're really at the end of your rope and you feel like, I can't do this anymore. I have to do something different. And those are really what we call narrow windows of opportunity. They come and they go really fast. And so with alcohol and drug addiction, the key is to be available and move rapidly while that person is at that level of discomfort that they really cannot tolerate this kind of lifestyle any longer at that point in time. And so you work on those windows of opportunity. The other people are wanting to stop, but I will tell you that in all these years, I've met maybe 3 people that sincerely wanted to stop when they said, I need help. They usually had an ulterior motive. They didn't want to lose their job. They didn't want to lose their spouse. They didn't want to live on the street any longer, but they really had not come to the place where they were ready to make a lifestyle change. So alcohol and drug treatment has to work with people who don't quite know yet what they want to do. They just don't know. They just don't want to do what they've been doing. And often today, with all the mix of drugs, we don't see a straight alcoholic much anymore. We see people with alcohol and a variety of other drugs, most commonly today, fentanyl and methamphetamine, and usually in combination. And what we're seeing is some of the symptoms as the fentanyl gets stronger and stronger is that they are hallucinating and they look mentally ill, and the hallucinations may go away with the proper treatment and with bringing them down from that level of intoxication. And they're often wishing they could die because they feel so awful, but not necessarily due to a mental illness. It's simply a more transitional desire to die. And so the work of the detox program is to really ferret out those that are in long-term chronic mental health conditions versus those that are in transitional drug impacted mental health conditions. And our services in detox have grown tremendously. When we started, we had detox with people in recovery staffing it, and really no medical advice or support. What happened is the emergency rooms might give you, bring a person to you who's got a prescription and say, here, give it to them as they need it. Well, it didn't take too many years for us to figure out that that really wasn't the right way to do things, and it was basically illegal. And so nowadays we have a few of the medical detoxes left, and many of them have gone away for lack of adequate funding. And so what we do is find the medical, the pharmaceutical ways to help people go through withdrawal or to transition to a medication that is for recovery. And that may be Suboxone, Subutex, Sublocade. It might very rarely be antabuse and some other drugs that are available. So it's an individualized approach to each person. And in each 16-bed facility, we see about 1,000 people a year. And in a short-term detox period, it's getting longer. And today with fentanyl, the detox really needs to be 10 days because the person is breaking through. We can treat the withdrawal And after 3 or 4 or 5 days, they look like they're okay because of the medications they've been receiving. They go off to a treatment center or go back home, and they immediately go back into withdrawal because they're no longer getting the medications. So we're having more conversations with doctors and hospitals and health plans about, can't you make this a longer period, because the fentanyl is changing the game in terms of what's the standard practice for a withdrawal period.
Linda,
And
I'm so sorry, I apologize to interrupt, but we'll probably just need to take another minute and then we'll have to wrap this up. Okay, thank you.
so one of the things I want you to know is that probably 3/4 of the people who work in our withdrawal or in our detox programs are people with lived experience. Lived experience is not new to our field. If they were not personally impacted with their own recovery, they often are family members, and there's a lot of understanding and compassion in detox programs. So I'm always here at CRIS advocating for, don't forget detox is a part of the crisis system. When it's substance use disorders, they are there. They're underutilized, they're underfunded, and they're going away. I remind the healthcare authority we're the canary in the coal mine, and the canaries are dying. And so I am always trying to get attention to the fact that we need to pay more attention to the detox, because alcohol and drugs are a long-term problem and they're going to be here for a while yet. So thank you for the opportunity to do my little spiel.
Thank you so much, Linda, for in particular raising a topic that we don't talk enough about. And we're grateful for you bringing that to this table. I had some nice chats from Michael Robertson, one of our CRIS committee members, who's also been trying to bring this issue more to the forefront. And so very grateful for your words this morning. I keep saying this morning, what's wrong? You'd think I was jet lagged. I mean this afternoon. All right, let's move along. I am very pleased to say that we have a new CRIS committee member representing lived experience. This person, for many of you, probably needs no introduction, but we want to make sure that you know how wonderful this person is. And so to make the introduction, I'm going to ask Vipasha Mukherjee to tell you a little more about our new CRIS committee member.
Hello, everybody. This is Vipasha, lived experience on the CRIS and on the steering. I'll be honest and say my words won't fully capture how happy I am to introduce you all to Kristen Wells, our newest lived experience member on the CRIS. Since 2022, Kristen has consistently worked hard to co-facilitate with us the lived experience subcommittee meetings, bring speakers to the CRIS, and a lot more, because she believes the voice of lived experience is key to building the behavioral health crisis response system. I have witnessed Kristen blend her lived experience with her experience as a social worker and her unwavering commitment to social justice in the most beautiful way. I have learned a lot from her, and we are very lucky as the CRIS to have her unique voice. Welcome, Kristen.
Yay, Kristen. And if you'd like to just say a few words, please feel free. You have the floor, or whatever you'd like.
Thank you, Vipasha, and thank you, Jamie. My name is Kristen Wells. As Vipasha mentioned, I have my own lived experience. I've also been the primary caregiver for a spouse during a period of crisis, and grew up with a sibling that struggled with significant mental health difficulties. I'm also a licensed social worker, and I provide after-hours crisis services for one of the community mental health agencies in King County. I'm really excited to be here. Thank you.
Welcome, Kristen. Okay, Chloe, if you wouldn't mind putting the slides back up, I'm just going to walk everyone through our agenda for today. You can start with the page that has our meeting objectives. Okay, so today, as ever, key objective is to ground our work in the personal stories and experiences of people who encounter the crisis response system. And then a big focus of our meeting today is to articulate potential performance metrics for the crisis response system. As our CRIS committee members know, this is a topic that we have been touching on throughout the past 2 years of work together, but we are getting to the point in our process where it's time to really dig in and start thinking about what those look like. We'll confirm action items and next steps and hear public comment. So if you could advance the slide, please. All right, so here we are. We're just finishing up with the second agenda item, and then we'll move into our personal story, followed by system updates and Q&A. So you hopefully received and reviewed your monthly newsletter, and that will be your opportunity to ask questions. We're also going to hear an update from Kristen and the Lived Experience Subcommittee regarding the personal stories project that we talked about at last month's CRIS meeting. And then we're going to move into the performance metrics discussion. We're going to start with an all group discussion here in the main room. And I'll show you how we're going to do we're going to kind of try out our framework for how we're going to do these discussions today. Then we'll take a break at 2:15, and at 2:25, our CRIS committee members are going to move into breakout rooms, three different breakout rooms, where they're going to continue the same exercise that we did in the main room together. I'm going to stay in the main room with community members and guests, and we're going to also do that exercise together in the main room. So we're going to get your point of view, community members and guests, and that'll be your opportunity to turn on your video camera and participate in the discussion. We'll come back together in the main room from the breakouts at 3:25 to do a share out and just kind of a synthesis of what all the rooms talked about. And then do action items and next steps at 3:45, move into our public comment period at 3:48, and adjourn at 4 o'clock. As of now, we don't have any signups for the public comment period. Community members and guests, and this is just for community members and guests, if you would like to make a public comment at the end of today's meeting, please send a chat message to Brittany Thompson, and we will take you in the order in which we receive your names. We will likely do 2-minute time limits for each public comment. However, if I get a lot of signups, I reserve the right to shrink that down to 90 seconds. But please do let Brittany know if you need an accommodation. For example, if you have a condition or situation where you might need a little bit more time to make a comment. I also want to remind everyone that making a public comment on the camera today is not the only way to get your voice heard by the CRIS committee. You are also welcome to send an email to the project email box, and we'll put that in the chat for you a few times during today's meeting. And those get compiled and distributed to all of our CRIS members prior to each meeting. And no one way of providing a comment is more important or valued than another. We value and review all of them. So again, you may send a chat to Brittany Thompson if you would like to make a comment in today's meeting. And again, that's reserved for our community members, CRIS members, not you. You already get to talk in today's meeting. Or you may send an email to the project email box, and we'll put that in the chat. All right, I think we can take down those slides now, and I'm going to turn it back over to Kristen Wells, who is going to introduce our personal story for today.
Hello, everyone. I'm happy to introduce our lived experience speaker for today, Ashley Albert. Ashley's from the Rainier Valley area of Seattle and has extensive experience with the foster care system, mental health systems, carceral systems, and family regulation systems such as CPS. Beyond her lived experience, she has become an advocate and community leader, helping others with similar experiences become decision makers in their own healing and recovery. Ashley loves being of service to her family. She loves music, dancing, singing, travel, food, sunrises, and sunsets. She shared with us that she's starting to like dogs and is learning to accept love instead of only giving it. Ashley, we're so glad to have you here with us today. Please start whenever you're ready.
Good afternoon, and hello, everyone. Can you all hear me okay? Awesome. I've been looking forward to get here today. Thank you so much for allowing me to come and share my personal story here at your meeting. I just want to give honor to all of the people with lived experience who continuously and tirelessly set a path that people like me can walk down. I want to tell you all about, my experience with system as it relates to crisis. You know, I first of all, I am in recovery. I'm wearing my recovery over everything sweater. I will have 7 years in July. I have always had mental health since I was a young girl. However, it didn't come apparent to me that I was set to be made different, feel different than from the rest of my peers until I got into CPS. And I need to tell you all the truth about our state and what's happening. My children were adopted. I was a former foster youth myself. I came in the system at 9. I aged out at 18. I got pregnant at 14 years old, and I had my first child at 15. My grandmother, who was my guardian, had to become a licensed foster parent in order to keep custody of me and my siblings. At that time, they had a unit called the African American Unit that would support African American families. And I remember so clearly the mistreatment that we received. I really want to talk about this specific bill. Actually, it's a federal law. Our former president, Bill Clinton, passed this law, and our current president, Biden, wrote the bill when he was Senator Biden, and that is the 1997 Adoption and Safe Families Act. That came into play in the foster care system sometime after the foster care system was on a roll. And I do understand that when that federal law came into place, its intent was to get permanency for children that were in foster care and not allow them to linger in foster care without a permanent home. During that time when this law was passed, there was a crack cocaine epidemic that hit the African American community really, really hard. And when that happened, it took parents, mothers away from children. It tore families apart. My grandmother had to raise me. I was angry at my mom. Family was telling me not to be angry at her. She had a disease, but systems was saying different. I was confused in regards to how I was to feel towards my mother. Had I known today the amount of forgiveness and work that it takes for me to work through that stuff, regardless of who's at fault, I need to be able to forgive my mom so that I can have better relationships, not only with my kids, but with other people. When this law was passed, I was 9 years old at the time. And like I said, I didn't age out until I was 18. And during my childhood, I was in and out of juvenile detention facilities, mental health facilities. I had suicide ideation way before I was able to form a sentence. I slept walk. I had a lot of, emotional challenges. And I'm so grateful for my grandmother that she had a background in childhood development, which allowed her to give her capacity and some grace to really, really like love on me. I will say that when you have a child with behavioral challenges, it's extremely hard. And I'm so grateful for my grandmother. This law is something that continuously to haunt my family. Yes, I aged out of the foster care system, and I came back in at the age of 23. And when I came back in at the age of 23, I was asked to voluntarily, come into agreement with the state to get services for me and my kids. I was really eager to do that. I was very naive. I was young and I was scared. I had always had mental health. And the dilemma that I had was if I didn't voluntarily agree to this, then DSHS was going to file a motion of dependency on me anyway. And what I will say to you is that when I first came into that system, I was told that losing your children was not a trauma. Losing your children was not a crisis. But as not only a parent that has gone through this experience, but someone that still works with parents, the most aggravating and compelling point when we touch with a parent is at that first 72 hours when the child is being removed. Parents are feeling hopeless, they're in despair. All kinds of stuff is happening. So I just want to say that as it relates to me, my children were adopted. I am the first parent in Washington state to legally enforce and modify an open adoption agreement. That is something big for someone like me that comes from the Rainier Valley area, that has criminal history, substance use, alcoholism, codependency, all of the things that unhealthy ways of communicating and engaging with people. I take a lot of pride in that because I fought the right way. And I used the system to help me, a system that was used against me to remove my children. It was not mentioned in my case that I had mental health. I did not get due process. It was never mentioned that I had always had diagnosis of suicide ideation, post-traumatic stress disorder, depression, since I was about 6 years old. Had that had been mentioned to the courts, the experience that I had going through that would have probably been less aggravating. It was really, really dark. It was hard. And I wouldn't wish that on anybody. I wouldn't wish that on anyone. It really was embarrassing. The bar kept getting set high, and no matter how many times I completed or met the requirements, the new ones were set out for me to be made. It didn't matter if there was a professional or an attorney or even the judge that was hearing my case. No one had power to stop or help what was happening. People had suspicions, they made comments, they made statements. My attorney even went to the extent of putting a protection order on my record, my medical records, because the state was using things inside of my foster care records that I hadn't even known about as a way of not allowing my children to be with family. When this took place, it caused a lot of issues. Can you all still hear me? Okay, I got a call. It caused a lot of issues between me and my mom. We had we had challenges, right? Because by the time she got clean and sober and came back into my life, I was so angry at her for picking drugs and alcohol over me that I couldn't understand. I didn't believe that she loved me. I didn't know that it was a disease. I had no idea. I had absolutely no idea. And it took a while for me to be able to amend that relationship with my mother. And me and my mother are on good terms, and she is my biggest supporter through this experience of I'm being separated from my children. And currently today, I will just say that I guess I just want to say that going through the foster care system is a crisis. Kristen, I'm trying to remember exactly what you and I talked about, because when we were on that call, you all had told me that what I was saying was really important. And what I want to say is that I tried to kill myself dealing with DCYF, DSHS, whatever you want to call it. I did. That was hard for me. I'm doing so much better now. And when I say I'm doing better, I am helping other families not have to experience what I have gone through, particularly families of color. I did some research, and I learned about the numbers in adoption. A lot of children that come into the foster care system are there for neglect and poverty. And the number of colored children, Black and brown children that come into the system and do not get reunified with their families, the children and then the parents that get their rights terminated are extremely high. The money that was spent collectively given to states from 1998 to 2020 was over $942 million. States get paid incentives to give children with families. Not one time was I offered any support or help to be able to parent my own kids. Having mental health doesn't make it impossible for you to parent your kids. It makes it a little bit more challenging, but it's not impossible. I was made to feel like I would never recover and I would never get better. I had to have therapists and social workers. I mean, folks all over just speak on the behalf of me and my children to make sure that we are being handled with care. The lack of support that we had got was so frustrating. I was really, really angry. And I didn't realize that anger I had towards my mom, when we had that crack cocaine epidemic and I would call my mom a crackhead because I was mad at her. I know we all have heard that slur, that name calling. That name was given by government when they called women crack queens and welfare queens. When women weren't allowed, when we were looked at for not being married and we were having children out of wedlock, the amount of like the pressure that we got put on us to be able to meet certain requirements and marks. I know this because this is the continuous conversation that I've been hearing since I've been a little girl in the home. And I wanted to prove my grandma wrong when I was super honest about what I was going through. I didn't have any intentions of lying. They told me that, Ashley, we want to help you get housing. We want to support you and your mental health and be able to parent your children. But all of those things were used against me. And when it did, it backfired against me. So I had not only that information that I shared with the state held over my head, but now I lost the trust and confidence and support of my family and community because they say we don't give our kids away. That's not what we do in our community. And it was extremely painful. As of today, with that adoption stuff, I signed papers, an open adoption agreement that would allow me to have visitation and communication with my children. None of that was followed. If you all remember what it was like to make a deal with your friend when you were a kid, and when someone has their fingers crossed behind their back, but they're shaking your hand, we know that means that deal is void. They don't really stand on that. And that's what it felt like when I signed those papers and was told that you sign these papers, we're going to get you to be able to see your kids. But if you don't sign these papers, you'll never see your kids again. And I went into a really, really dark hole. I went further into substance use, further into alcoholism. I was looking for love in all the wrong places. I was doing things that I never did. My mental health got worse. And my grandmother that raised me had to move into my apartment that my children had left to be able to support me so that I wouldn't commit an act of suicide. And these are the things that I've had to live through and that my family has had to live through from the time that I've been able to, move my arms and legs. I'm currently right now had to file a complaint with the Federal Office of Civil Rights in regards to my disability not being mentioned when I was going through this process, and then also the statements that was made towards me in comments as it related to me being a woman of color, African American girl. So when statements were made, like when I didn't agree and I was called defiant or combative instead of strong and boisterous and knowledgeable and resilient. You know, it came off that I wasn't trying, or I wasn't in agreement, or I wasn't trying to collaborate. I had to file this because I had no idea that I would even have to go through CPS, and I never experienced that my children would be taken from me because of my mental health. No matter how it was written or how it was said, going through an experience like this, when you were formerly a foster youth in the system that never got services, to be able to rectify some of that you know, the ACEs, the hole in your heart, right? And then we come back in as parents and losing our children, that is definitely a crisis. Because now at this point, I can't differentiate and separate my experience from being the child from my experience being the parent. So
Ashley,
today,
Ashley, I'm so sorry to interrupt you. We'll have to wrap this up pretty soon. So do you think like
I'm done.
Yeah.
I'm about done.
Okay, thank you so much.
Thank you. So all I was saying, I forgot where I was leaving off, but
You were talking about how not having the tools to support your own children and not getting the support from the system, just the kind of ripping you apart was what you experienced. Does that help?
yes, thank you. And being yes, that helps. And being an African American girl that has lost both parents and has emotional challenges and is called defiant and combative and ADHD and anxiety and all of these acronyms and diagnoses with no love or open arms or support has just further sent me into a place of I can't focus on helping myself. I need to get my kids out of the system before what happened to me happens to them. So I just say to you all that I didn't kill myself. My kids are back because it's a failed adoption. It still is a crisis because the adoptive parent didn't sign over the papers and is still collecting money. But I'm still here showing up to try to make sure that we're changing the narrative of how families that are coming into the system, the lack of support they get and what is actually needed. And if we could just have, and I'm closing up, Jamie, if we could, just like there's drug court and mental health court in the criminal platforms and systems, there's family court in child welfare dependency court. There's no mental health court or, you know, trauma-informed approach for families who were formerly or have lived their whole entire life in the system. And I just feel like had there been acknowledgement of that and support, that the pathway to get to the solution would have been a lot less shorter. So thank you all for what you do. Keep doing what you're doing, and I'll be seeing you around.
Thank you, Ashley. You touched on a lot of really big points that I think it's very important for us to hear. You touched on generational trauma, as well as how the systems have in the past been used to cause more trauma and how they continue to cause trauma. We want to make sure that the systems that we are putting together are helping the community rather than harming them. And hearing from you about your experiences gives us a window into why many people have a hard time trusting the systems that we're putting in place. Ashley was open to hearing from CRIS members privately, so her email will be shared to folks if they would like to follow up with Ashley and ask any further questions or hear more about her story.
I just sent
Oh,
this. Oh, sorry, go
Jamie,
ahead, Ashley. Yeah.
can I just say one more thing? I just want to let the committee know. I have partnered with the Washington State Coalition Against Domestic Violence. I am a DV survivor as well. And I have wrote a book to help survivors to be able to tell their stories, and it's called Owning Your Story and Claiming Your Power. You could find that at the Washington State Coalition Against Domestic Violence, and it's all focused around domestic violence and CPS. I'm trying, I'm helping, not only sharing my story, but I'm trying to help other people be able to share theirs too. So thank you.
Ashley, thank you so much. You seem like an incredible person and an incredible parent, and I am very grateful for you coming and sharing your journey with us. And also, you know, in the midst of the stories about that really reinforce why so many people don't and shouldn't trust the system, also offering us a message of hope too. So thank you for that. And I have something in the chat here from Puck to put in the group chat for all of you. Okay. So I think we're going to move now into our system updates. And we're going to start with, you all should have received the newsletter with the updates from the state agency. So we will do our usual opportunity to ask questions, clarifying questions from Michelle Roberts and Tisha Kirschbaum, who are both here from DOH and HCA respectively. But before we do that, Kristen, you're in the hot seat a lot today. I'm going to ask you to come back up and provide everyone with an update on the Lived Experience Stories project that was first presented to the CRIS Committee, or briefed to the CRIS Committee at last month's CRIS meeting. So Kristen, I'm going to turn it over to you.
Sounds good. So we've continued to discuss how we want to engage in this process for this project after receiving feedback both from the Lived Experience Subcommittee and from all of you at the last CRIS meeting. We've recognized the importance of exploring all aspects of the behavioral health crisis system. So our plan is to seek stories about people's lived or living experiences with any part of the system, rather than focusing on a specific piece such as calls to 988. Our plan at this point is to do the project in 2 phases. The first phase of the project will be a general call for people who have engaged with any aspect of the behavioral health crisis system within the last 2 years to submit their story, provide some demographic information, and let us know if they would be open to having a more in-depth interview later in the project. As we collect these stories, we'll look at themes and patterns. We'll also use the demographic data to identify communities that we're not hearing from and seek ways to outreach directly to those communities to gather stories. Sean, our lived experience at the end of 2023, who you might remember, was only able to share his story about his struggles, including substance use and homelessness, with support from Puck. And as a good example of the kind of stories we might be able to hear when we directly outreach to people who are unable or uninterested in coming to the CRIS or CRIS Lived Experience Subcommittee meetings to present stories on their own. The second phase of the project will be setting up interviews with people who were open to meeting with us and whose stories are likely to present opportunities to explore specific gaps in the current system in depth. These interviews will give us opportunities to explore what happened when a person entered the crisis system, whether that matched what they expected or needed in that moment, what would have been more helpful if their needs were not met at that time, and give us information that will help us identify why their interaction with the crisis system went the way it did. Like in the story we presented last month, where we identified that a caller's long wait was due to their call going to an out-of-state backup call center. Based on these gathered stories and interviews, we'll make specific recommendations for system changes that improve the capacity for the system to meet the needs of our community in the future. These stories could also assist us in drafting a crisis system Bill of Rights, as suggested last year by Senator Dingra, based on the needs and expectations communicated to us by the community members. We will continue to report back about our progress and request feedback as we develop more specific plans for carrying this project forward. We'll need some resources and some support as we complete this project and would love to hear from anyone who's interested in helping us. Thanks.
Okay, so I'm going to open up to CRIS Committee members now for questions. First, if you have any questions for Kristen or the Lived Experience Subcommittee regarding the Lived Experience Stories project, or if you have any broader questions for HCA or Department of Health regarding anything you read in the monthly update newsletter. So CRIS Committee members, please let me know with a raise of hand if you'd like to offer a question right now. Pasha.
Yeah, I just have a question about, the first part has 3 mentions of rulemaking. One for the crisis contact hub centers, the 23-hour crisis relief center, and the peer support. I get that the first and the second one came sort of out of the work of the CRIS. How do y'all pick which ones to update us on? Because based on my emails that I get from DOH, just signed up as a community member, there are other rulemaking processes too. Like right now, I think it's the agency affiliated counselors. There was some rulemaking that happened around that. So I'm just curious about why, certain things are reported and certain things are not.
Keisha or Michelle, do you want to see if you can take that one?
Yeah, I think I can speak for DOH, but we are, Bipasha, trying to hit the ones that are related to crisis system work and pieces that are touching it, and especially the rules and laws that are being passed and that require rulemaking directly related to the CRIS work. I can see, thanks for flagging that there was an agency affiliated counselors, which is probably a healthcare scope of practice rulemaking. And so we could go back and talk to make sure we're not missing anything, even that could more tangentially touch behavioral health work. So thanks for flagging that.
Thanks. I just, because we've talked so much about the fact that we're so short-staffed, and this is part of speaking about like staffing, because we want more, if we can have people getting licensed at the master's level, agency affiliated counselors do fill that gap. So I think that's something like that is important too. Thank you.
Great question, Bipasha. Thank you for getting that clarification for us too on how this information is selected. Darcy.
Hi, I have a question related to the Healthcare Authority Award for the bed registry. And I am curious if there's a timeline for the contract that's going to be executed. I see in the newsletter that it talks about having the lived experience subcommittee be part of the about giving input into that. But I also, the other big stakeholder with this are the people that have the beds. And I'm curious about what the plan is with the Healthcare Authority to include the psychiatric units in the psychiatric hospitals, the ENTs, and with the ability to provide input into that.
And Darcy, just to make sure everybody heard, can you remind everyone what specifically which piece?
So this is in the under the crisis system technology platform section of the newsletter. And this is about the bed registry.
Got it. Okay. Tisha, do you have is that something you can respond to now? Okay.
I'd love to. Hi, everyone. Again, I'm Tisha Kirschbaum with the Healthcare Authority. Yeah, absolutely. We plan on also speaking to the groups that you had mentioned. Absolutely. I think we just, you'll only have so much space in the newsletter to be able to update things. So that's where we mentioned, I believe some of the other stakeholder groups that we really want to make sure we touch on are, of course, behavioral health providers, emergency departments, first responders, of course, the hospital association and all of those different parts. We'll be looking at probably BHASOs. I guess some other stakeholder groups will also kind of bubble up as we kind of get farther into the process.
So Tisha, it sounds like some very broad stakeholder outreach is planned for this.
Right. And what I very much appreciate is you bringing up like, hey, I see you doing this, but what about this particular group? We're always open to that feedback to make sure that we are reaching the stakeholders that we should be.
And just a follow-up question, is there a timeline for when this is going to happen?
Oh, I think we're just getting the contracts executed with the organization that's going to be helping us with this work. So I'm not 100% positive.
Tisha, is that something you could keep this group apprised of, given that there's probably a lot of interest in that? So as that timeline evolves, you can share it with us, maybe in the newsletter.
Yeah, absolutely. Thank you.
Okay, excellent. So Nicola, let's put that in one of the action items too, so we can just track that for future newsletters. Darcy, anything else you want to ask there?
No, that'll do it. Thanks.
Okay, thank you. Anna.
Hi, I don't really have a question, but more a comment for Kristen and the Lived Experience project. NAMI Washington would be really interested in helping out in this effort. I can reach out to, we have 20 affiliates across the state, reach out to our affiliates to see if people are willing to share their lived experience regarding the 988 system. And so I just want to let you know to please contact me after session and we can talk.
Thank you,
Wonderful.
Anna.
Thank you, Anna.
Thanks so much for that offer. And I have a note in here from Kashi asking for a future newsletter. Would love to understand if youth/minor beds are in scope for the bed registry program as well. So I'm putting that on your radar, Tisha and Sherry, for a future newsletter. Alicia.
Hello, sorry, my bandwidth is not doing well today, so I'm going to remain off camera. But my name is Lacey and I support the fire departments with the CARES program, and I oversee a behavioral health alternative response team in the city of Tacoma. One question that I had about the newsletter is that I've seen this month and last month there was conversation about endorsed teams and providing some information to the CRIS prior to those things rolling out so that we can have a better idea of what that's going to look like. And April 1st is coming very quickly, so I just don't know if there's an update about that. Thank you. For the mobile crisis.
Okay, thank you, Lisa.
Sorry.
Alicia, I was just
sorry, underneath the mobable crisis component.
Okay, so you're wondering when there's going to be an update to get the CRIS's input on that. Tisha, is that something you could answer now, or is that something we should maybe flag for later?
Yeah, I think I want to take that one back. My guess is that maybe we were a little ambitious with our April 1st deadline, but let me follow back up on that one.
Okay, thank you for that. Appreciate it.
Yeah,
okay, we'll add that one to the action items too, and we'll circle back with you. Thanks for raising that, Alicia. Any other questions from the CRIS on the newsletter or the information that Kristen presented about the Lived Experience Stories project? Okay, then we are going to move into our next discussion. And this is introducing the main topic for the meeting today, which is performance metrics for the crisis system. I am going to start by sharing my screen. Bear with me just a second here. Okay, I know this is going to look like a lot, but I promise we'll just take this in pieces. I'm going to zoom in so you can see. All right, so we're going to start today. Actually, I'll back out a little bit. Hopefully everybody can see, but let me know if you need me to zoom in anymore. I'm going to start today by setting the table for this work that we're going to be doing as a group today. So 2 years ago, this committee, with the help of an ad hoc committee that worked in meetings outside of the CRIS committee meetings and then brought content back to us, this committee created a vision for the 988 crisis response system. And I know that we all were pretty familiar with it back then, but we thought it would be very useful to reorient ourselves to this vision before we started talking about performance metrics. So I'm going to take one step back here and say, again, I said this earlier when we went through our agenda, but I want to reiterate the objectives of today's discussions. We want to remind ourselves, first of all, of what an effective and equitable crisis response system looks like, which is this CRIS vision. And then we want to actually articulate what these guiding principles look like in practice. So we want to take them a little further down the funnel in terms of specifics. And then identify potential metrics for measuring the extent to which we are fulfilling these guiding principles, or we're meeting these guiding principles. So what we're going to do, I'm going to just zoom out so you can see the whole board. What we're going to do is we're going to actually do an exercise as a group together, this first one in the red box here. And then CRIS committee members, you're going to move into breakout rooms. And you're going to keep doing this exercise with each guiding principle that was assigned to you. Answering the questions of, what does this mean in practice, and how might we measure whether this happens? And community members and guests, you're going to do that with me in the main room too. So you're going to be part of this conversation as well. And then we're all going to come back together in the main room and debrief. Now, I realize this is a lot. There are actually 10 guiding principles. And so I'm just going to ask that you do your best to get through as much as you can today, but please don't feel rushed. We actually are going to be talking about performance metrics at our March meeting as well. So if we need to continue this conversation into March, that is okay. I would much rather give this a quality amount of time rather than speed through it too fast. All right, so I'm going to just walk everyone through these this vision again, so you all remember, and those of you who are new to the CRIS are grounded in it. This is what we agreed to 2 years ago. The vision for the 988 crisis response system is to build understanding, hope, and a path forward for those in need, where and when they need it. And we articulated 10 guiding principles to support that vision. The first 4 are: people in crisis experience timely access to high quality coordinated care without barriers, a welcome response that is healing, trauma informed, provides hope, and ensures people are safe, person and family centered care, and care that is responsive to age, culture, gender, sexual orientation, disabilities, presence of disabilities, geographic location, language, and other needs. So those are the first 4 guiding principles. And then the remaining 6 are: the crisis response system is intentionally grounded in equity and anti-racism, centered in and informed by lived experience, coordinated and collaborative across the system and community partners, operated in a manner that honors tribal government to government processes, empowered by technology that is accessible by all, and financed sustainably and equitably. So those are the guiding principles that we agreed on a few years ago. Wanted to make sure we reiterated that. We're going to take that first guiding principle: people in crisis experience timely access to high quality, coordinated care without barriers. And we're going to work together on answering those 2 questions that I'm asking. So I'm going to bring this up and zoom in a little bit so that you can really see what's on here. So my first question for you that I'd like CRIS committee members to think about is, what does this mean in practice? And I put an example in here, which is no one is turned away when they call for help. But that's just one example. I know there's a lot of ways in which this should play out. And then how might we measure whether this is happening? An example is the percent of persons seeking care who are turned away due to lack of coverage. Obviously, the more we're achieving this, not turning away folks who need help, the lower that percentage falls. So CRIS committee members, why don't you take a minute or 2 to think about this and what your answers to these 2 questions are for this particular guiding principle. And it's okay if you can only have an answer to the first question and you haven't nailed down the second question answer, or vice versa. But take a minute or 2 to think about that, and then please raise your hand. I'm going to scribe for us what you have to say in these white notes here.
I think this is just a lot, Jamie.
Who just said that? I didn't see that.
Sorry, this is Puck.
Hi, Puck.
I'm one of our lived experience kids, and I'm thinking about the experience that Sean shared in December, and just like the number of barriers that came up. Like, there are so many. And so trying to break this down into like tiny instances, like that's really challenging.
I hear you. So is there another way that you think of how you might be able to approach this question? Because I recall Sean's presentation. I agree with you. There were so many barriers that Sean encountered. So I understand you're feeling a little overwhelmed looking at this. How about if we try this? We're not going to be able to solve all of it. And there's probably a lot of, like you said, a lot of pieces, but building the cathedral, we have to do it brick by brick. So let's maybe start with the ones that come first to your mind.
One of the first things that comes for me is one of the things this would need to mean is that translation services are available for anyone that needs to access the crisis system. And then we would need to be tracking how often people seek help and aren't able to get a translator.
So this is addressing that barrier of language access.
Jamie, I don't know about others, but we can't see the thing that you're typing. Is that true for everybody else? Can you see Jamie's boxes up there?
I can see her adding things to boxes.
Yeah.
Okay. Betsy, it might take a minute to refresh on your screen, but please.
No, I'm sorry. It's not an issue for everybody else.
Okay.
Your bars are just kind of blocking mine, but it might be just the view I have. Go ahead.
I can also move it down here.
Yeah,
I'll do what I can to kind of move it around so you can see it. Thanks, Betsy. All right, I see Kashi and then Anna. Kashi?
Okay, you can tell me if I understood this wrong, but one of the things I would say to put on the left-hand side is that we want people to, I'm going to say youth because that's my world, youth to have access to the evidence-based intervention, which to me would be the percent of youth who get connected to mobile response or MRSS. Or number if we don't know the denominator of youth.
Okay, I'll do that. And everyone who may have missed the wonderful presentation a few months ago from HCA, MRSS stands for Mobile Response and Stabilization Services, and this is a particular model for youth, transitional age youth, and young adults. Kashi, did I say that right?
I believe so.
Okay.
And there's great things the adult system can learn from MRSS, but yes, it is the evidence-based intervention for a youth in crisis.
Perfect, thank you. Anna.
So for me, I wanted to emphasize the timely. A lot of the complaints that we're receiving about people calling 988 is the amount of wait time. They're put on hold when they're in crisis, or they're redirected multiple times, and it's taking a while for them to actually get to a person to talk to. So I think, so in measuring that, I guess you could say, like, how quickly from the time someone dials 988, how quickly are their calls being picked up to talk to a live person, not a machine? And how quickly are they actually getting to a person that they can talk to, like a counselor?
And I know that that is a national best practice as well. I was thinking about the material that that particular measurement that you called out. I was thinking about the material that Nicola sent out with the meeting. So thank you that's a really important one. Thank you for calling that one out. I just want to remind everyone, right now it's just CRIS committee members participating in this discussion, but community members, guests, you will get to participate when after the break, we're going to do a facilitated discussion in the main room. And I really do want to hear your point of view on some of these. So I'm looking forward to that conversation. Kim.
Hi, thanks. Yeah, so I had a couple thoughts building off of what Anna was saying around the timeliness. I think my recollection is there was also a attempt to kind of rank, certain responses like emergency, sort of non-emergent, urgent. And so if we are considering, if we can measure that, then if there's a certain time period in which people could expect an actual response, not just getting through on the phone, but like an actual response if that's required, that is quantifiable. We should be able to, if they're being categorized, we should be able to see how well we meet those needs. I think the other items that are in here about high quality and coordinated care to some extent, and without barrier, to some extent, that's hard. That's not quantifiable. That might require sort of talking to the folks who use the service, right? And understanding how satisfied they were afterwards and what the result of that service was. You might be able to measure maybe coordinated care a little bit better if there's some indication that there was actual coordination or connection with other service providers. But, whether that's a high quality service or not, I think you have to spend more time talking to the folks who use the service then.
And Kim, to clarify, when we're saying high quality service, are you thinking this is in terms of how the individual defines it, or are you thinking it's like, did they have a positive outcome? What's your thought there?
Like, I mean, I'd be curious what other people are thinking. When I think high quality service, I'm thinking people used it and felt like it was helpful and it met their need. I mean, maybe we have some best practices, about the types of interventions we're providing. And so we can check the box that we did that thing, but if the person didn't feel like it met their need or was useful, that's probably more important.
Yes. Great. Thank you for that.
Yeah.
Fennec, hello.
Hello. I kind of want to continue off of what Kimberly was saying, and on that part about coordinated care. And for me, one of those pieces of what it would mean in practice is people being educated, everyone who's answering those calls, everyone who's involved in the system, knowing what the other parts are, where to send people, what other portions are doing. So that coordinated piece, right? Like, are we aware of what each piece is doing? And I think one way that we could measure it in my mind is how many transitions a person makes, right? If they're going to 3 different places before they get the care they need, then that tells me it's not coordinated well. If the person ends up in one more place, then that to me says it's most likely a well-coordinated system. So that's my thoughts.
Thanks, Fennec. Puck.
Yeah, that coordinated part is something that I wanted to highlight as well. I think we need to assess what we mean by that, because as Fennec brings up transitions before they get the service they need, like so many people through various resources at Sean, and those resources didn't pan out, and he spent tens of hours trying to chase down all these leads that we were given. And I think the dream would be for 988 to provide like informed referrals rather than just, throwing phone numbers at people. And also to like potentially have a sense of like what resources this person has already been given, right? Like not providing the same unhelpful resources repeatedly. That to me is coordination. And I just think that we need to look more at what coordination means.
Okay, so I'm gonna this is an important point that you make that's a little bit of a nuance on the question. So I'm gonna do this in a comment, which is we need to maybe spend some time understanding or defining what coordination means.
Yeah, because I think we have like an HMO model of coordinated care in our heads, but I think that coordination can start before we are working with any specific institution.
Okay, I'm gonna put that comment over there so we don't lose that. All right, thanks, Puck. Kristen.
Yeah, I wanted to go back to the timely access part. So we've talked a little bit about timely access when calling in, but for one of the other big entries into the crisis system right now is emergency departments. So for timely access, it would be how long from arrival to an emergency department does it take for someone to speak to a social worker, get an assessment done? And then from there, how long it takes for them to be transferred from an emergency department to somewhere like detox, inpatient, crisis diversion bed, depending on what they're needing.
Nice. Okay. Hi, Larry. Nice to see you.
Hi, Jamie. So this is kind of a follow-up on what a lot of people are saying, but I think we've covered it. But the question is how, when we look at the metrics, I think Kimberly brought it up earlier, but how are we going about in doing this? Because I think that so much of this is subjective. And if we go back to it, people in crisis are the center point. If we're not able to follow up with them because what they consider high quality or coordinated care is probably going to be different than what we set. And so the question is, are we going back to them for an evaluation, or are we setting our terms of what success looks like and then measuring them according to that?
So Larry, here are a couple of things I just want to make sure I'm tracking. So first is how, and this is getting back to that earlier question of how Puck raised about how we're defining coordinated, and I can't remember who might have been Kristen who asked, like, how are we defining quality, that someone's receiving quality care? So it sounds like you're raising the issue of we need to actually be getting community input and user input on how we even define that, and then we need to measure it against those definitions. Did I track that right?
Yeah, I mean, I'd start with the end and say if we say people in crisis experience timely access to high quality coordinated care without barriers, there's about 5 concepts in there, right?
Yeah.
And we're deciding what those concepts are and saying how you measure them. That's fine, unless we have access to the people that are experiencing that and checking with them, because there are going to be differences. What is, quick access to some people is different, timely. What's high quality is different for folks. So I say that because if we're truly going to be user-centered, we do want to build that in. We can still have our own metrics, but then testing them against what people say, even if you could only get a hold of 10%. Again, if we set out what constitutes coordinated care without barriers, we have a very different understanding because we're professionals about what that means. And whatever we set up may or may not actually track with people who are in crisis. So my point being, I think this is 2 things.
Yeah.
And we have to move forward, given what constraints we have. We may not have the ability to talk to people after. That's going to define in a lot of ways what we do. In an ideal world, we would be able to do that. And then that's kind of a gut check against all these other things we do. So that's kind of my point, is that what restrictions are there practically and otherwise in terms of how we would actually evaluate this? Because time and things like that, those are pretty straightforward. But I think there is this qualitative component that's kind of the big point, right? Is that we are not coming in and making decisions for people that we don't know.
I think that's a really great point. And when I was reviewing the materials on best practices, I was noticing that a lot of them were really quantitative. It's a lot harder with numbers to capture what an individual experiences in terms of, or expects or needs in terms of timeliness, or taking that kind of epidemiological approach is not going to give you all of the information you need.
Not only that, but I mean, it could get worse in the sense that we define it as successful, and those with the experience say that wasn't successful. So we know what the barriers and limitations are. So what we mean by timely access may be very different than somebody else.
Yeah. And Betsy Jones just sent me a chat message to remind me, I think this is a really important point to make, that lived experience stories project that Kristen Wells briefed everyone on during the updates period, that's going to be a really good opportunity to start to dig into some of these things. So thank you for raising that. I have a couple points in the chat, and then I do want to do a time check because we're actually a little bit past what we decided for our break today. So and this is a great discussion, so I don't want to cut it off. So we'll do a little time check in a moment. Alicia Morales writes, some questions that I have are, who determines timely access and what resources and services are we offering in a timely way? That's a really good question. And who determines what coordination is and what it looks like and what services and resources are being coordinated? So I'm just going to highlight these, and I think I really want to capture these. I'm going to put these in a comment message on the board because I think this aligns really well also with the points that Puck made earlier. And I think this is probably a conversation that this group needs to weigh in on. This is a theme I'm taking away from this conversation, is that we need to do a little more defining of these pieces before we can really think about how to measure. And then I see a note from Bipasha, a huge yes to what Kim and Larry said, that we are providing a service and the consumer needs to rate what that service felt like to them and then measure against internal system metrics. So, all right, I'm looking to see if there's any other hands at this point. Okay, we did a good job here. I think we got a lot of good content on here. I think now you all kind of understand how we're going to do this exercise. So here's the plan. We're going to take a 10-minute break. And then when you come back, we're going to send CRIS committee members into your breakout rooms. In your breakout rooms, there's going to be another board that looks like this one, but it's going to have 3 more guiding principles on it. Each room's going to have a different set of guiding principles to work on. And you're going to have a facilitator in that room. Michael Anderson Nathy is facilitating a room. Liz Argin is going to facilitate a room, and Nicola Pinson is going to facilitate a room. And you're going to just try to do your best. Don't rush, but try to get through, a couple of guiding principles. It's okay if you don't get through all of them. You're going to we'll probably be closer to like 55 minutes after our break to have your discussion in your room. And then we're going to come back to the main room to debrief. Community members and guests, you get to stay with me, and we're going to also do this exercise with 3 guiding principles, and we'll do our best to get through as many, but I'm really looking forward to your point of view on some of these guiding principles. So I have 2:22, so I'm going to be really precise. Let's all be back here, cameras on again. It's actually 2:23. At 2:33, we'll put a note on the board so you know when to come back, but if you could come back at 2:33, and then we'll send you into your breakouts. Thanks, everyone. Oh, and yes, facilitators, if you could please record your breakout sessions. Thanks for the reminder, Michael Anderson Nathy. I'll remind you again before we move on. Thanks, everyone. Have a good break. Okay, everyone. We had a good break, a little break there. We're about to move into breakout sessions for CRIS committee members. Before we go, I just have a couple of quick reminders for the facilitators. First and foremost, please, when you go into your room, first thing you should do is hit record on those breakout sessions. We do post the recordings of the breakout sessions on the CRIS committee website so that even if community members, even if you weren't in one breakout session, you can still see what happened if you're interested. So that's the first thing. We're going to take the full 60 minutes. I still don't have any public comment signups. So I think what we'll do is we'll take the full 60 minutes in your breakout and we'll all come back here at 2:35 to do a share out. CRIS committee members, your facilitators are going to invite you to volunteer to be to share out what your room discusses. You know, we're not going to force anyone. So if you just don't feel up for it today, totally understandable. Your facilitator can step in for you. But I do think it's always more compelling to hear from you than to hear from us, as wonderful as we are. And I will ask, when you think about what you're going to share out in the main room, what we really want to hear are some of the big takeaways. You don't need to go through every sticky note that your room comes up with, but more like, what were some of the big themes or takeaways that spoke to you that you think you'd like to share with your fellow CRIS committee members and guests. And then your facilitators, for those of you who haven't used the Zoom whiteboard like I was just doing, in your breakout rooms, you're actually going to get to work in them with your facilitator. It's not just going to be the facilitator, and your facilitator is going to show you how to do that. So don't panic if you've never used one of these. It's pretty easy, and your facilitator will teach you, but you'll also have some options if you'd rather just have your facilitator put your notes in for you. I think that's it for the housekeeping. So community members and guests, you're going to stay in the main room here. CRIS committee members, Brittany is going to send you off through space, through cyberspace, to go to your breakout rooms. And we'll see you back here in an hour. Okay, I'm going to change my view so I can see all of you. Community members, if you feel up for it, please feel free to turn on your video camera so I can see your faces. And I am going to share the whiteboard we're going to be working with here. All right, so here's that whiteboard we were all working on. We're going to go, we have our very own spot on this board. I picked 3 of the guiding principles for us to discuss together. So we're going to do, for those of you who got to see the previous exercise, we're going to do just what I did with the CRIS committee members before the break. I'm going to show you the 3 guiding principles we're going to work on, and we're just going to do our best to get through 1 or 2 of these, maybe 3 if we're really ambitious. So the first guiding principle we're going to work on together is people in crisis experience care that is responsive to age, culture, gender, sexual orientation, presence of disabilities, geographic location, language, and other needs. That's the first one we're going to work on together. If we get through that one, we're going to do the crisis response system is centered in and informed by lived experience. And then finally, we're going to work on the crisis response system is coordinated and collaborative across system and community partners. So those are the ones I picked for us. Let's start at the top here. I'm going to give you all just, as much time as you need to consider the 2 questions I asked the CRIS members for this first guiding principle. What does this mean in practice? In other words, what kinds of things will you experience or see out there specifically if we are meeting this guiding principle? And then how might we measure whether this is happening? And I'm going to remind everyone, if you could use your raise your hand function to let me know if you want to offer a comment or an answer to these questions. You click on that reactions button in your bottom toolbar and it pops up a window. and you'll see raise your hand. You can also feel free to send me, Jamie Strauss Clark, your thoughts in a chat, and I can put them right in a sticky note for you. And whenever you're ready, please feel free to raise a hand. I'm on mute. Vashti.
Something that having the family, because I also in the youth realm, but having the family or the youth define the crisis and define whether or not if they've been de-escalated on the call, then do they still want assistance to come out to help? Because maybe the youth is not in crisis no longer, but the family or caregiver might still be in crisis. So having them define those.
Okay, so in practice, I just want to make sure I'm capturing this correctly. So if we're meeting this guiding principle in practice, the youth and or the family are the ones defining whether this is a crisis. Let me get that down. And they are getting this. I want to make sure I'm tracking your second point. They are getting the response or services they need at the end of the call. So in other words, if it's de-escalated and they're cool and they don't need anything else, is the family, but the family still needs support. Are they getting that?
Right. So the family defines that.
Okay.
Makes the decision. So not the receiver of the call, but the family or the youth defines that.
Okay, I'm going to make that a separate one because I think that you're making Thanks, Vashti. Joel.
Hello. Mine is for meaning, not everyone will use or access a phone. So either like texting or another format for them to access the crisis line would be helpful too, because not everyone uses phone systems or feels comfortable being able to get onto a phone with someone, especially if they're in a place where they're a victim and they might have their person who's still harming them around.
Right, that is a great point. And I should have asked Vashti this too, but do you have any thoughts on how, and other folks can contribute to this. Did you have any thoughts that came to mind on how we measure this?
Yeah, if we do use these other systems, being able some way to see how they're being used, either by having some sort of system where it shows, oh, the use of this is up or down. I don't know how that would work. I'm not a IT person. That was what my thought was. I don't know if anyone could maybe express it or has another idea of how that could be measured.
Yes. And I do want to mention too, this system the service is in place. Elena Perry with Department of Health wanted to make sure everyone did know that there is a text chat option now. And Joel, I hear you saying, let's also track and see are people getting to use that?
Yeah, and it's not just texting; it's also other access points like the like Messenger. A lot of Messenger services for people who maybe use WhatsApp or Facebook or Instagram or other forms like TikTok even. So social media as a form of accessing the crisis line too.
Nice. Okay. And then I see. Okay, Vashti's provided clarification here. The caller gets to make the decision whether or not they want or don't want a mobile outreach, not the call taker. Nice. Kind of putting that in here. Thank you. Thanks, Vashti. Suram.
Hi. So I'm going to go back to what was discussed before the breakout, which is the best way to know whether the people in crisis got the care that's responsive is to ask them. And if we get demographic information about them, like some of the things here, age, culture, gender, sexual orientation, and then we ask them how the experience went, then we can combine that information to measure, is system responsive. So, and this is from their point of view. So that's, I think, one part of measuring this. So that's one piece of input, is just to kind of, so, it's a repeat of the same thing, but it's just another way to slice it. The other thing I was thinking about here is this principle, I'm presuming, applies across all three pillars. So when we think of responsive care, I feel like it's different when you're calling versus, let's say, if you have to go to a crisis relief center. Because the person with a disability, how do you get access to that? I mean, you may not be able to travel on your own, as opposed to if you're calling, or if you have a language barrier, how do you know that you need translations? I'm not quite sure how to make it a metric, but I'm just kind of saying that part of this is depending on what kind of service you're trying to get access to when you're in crisis, responsiveness is going to be very different.
Yes, I hear your point. So if I'm tracking correctly, you're saying that different levels of service, there are different barriers to getting different types of services.
Exactly. Yes.
And so,
and you have a language access, then you need translation services. But if you are calling to get help to go to a crisis center, I don't know. I don't know if are you calling to call the crisis line for that. Maybe you are calling the crisis line for that, or how do you give them directions? There's all these things. I'm not really sure, but I'm just feeling like, we tend to think a lot about just the crisis 988, but we are talking about a broader system, and so we kind of get these metrics for each of the different pillars, right? I mean, especially because the relief centers are walk-in. So if I'm in a crisis, I should be able to walk in or find a way to get there without necessarily having to call 988. That's part of it. So I'm not quite sure, Jamie, how to put it in clear words. So, but I'm just kind of more at this point, just, presenting a thought about.
So I think what I'm hearing from is that we need to think about, we're going to need to have different metrics for different types of services.
Correct.
Because maybe a lot of people can access mobile crisis, but we can't congratulate ourselves if they're not able to access the stabilization services that they would need after that.
Right.
Okay.
And maybe just, I think I don't know how to measure it, honestly. I think I'm still kind of noodling. I'm not quite sure what metrics that we could use other than to ask them, which is, I think the metric is, there is a metric which is to do the client service, which you put before, which is the thing we had before, and the other thing is a service. But beyond that, it's not clear to me that there is an internal system metric that we could track.
All right. So on the meaning side of it, it sounds like the relationship here is that people are able to, I mean, that it's kind of getting right back to that guiding principle, but people are able to access that service they need.
Well, it is, I mean, there's two aspects. There's one is the access to service they need. This one says that maybe it met their need, but it felt like it wasn't responsive enough to them. Right. So this feels like another flavor on that. One is just access. Yeah. Okay. Somebody, I'm just making it up, but if somebody was really rude and nasty, but you eventually got the help that you needed. Yeah, you kind of got the help, but didn't feel really good. Right. So it's kind of that this feels like a little more of a flavor on how there's a question of, did you get the help you needed? The other was, how did it feel to get the help that you needed, right? So this to me goes more to the how did you feel is how I think of the responsiveness aspect of it.
So this is back to that more qualitative type of Yeah.
Right.
Does anyone find that when they are typing for an audience, it becomes harder?
Yes.
Oh, that's funny. Okay, I think I see a chat here from Joel. The measure could be the call center making a report of where they sent them for services or referral. Yes. All right. Hey, community members, any other thoughts on what this guiding principle means in practice, or some ways we might measure some of this meaning here? All right, I have from Megan Hopkins with Department of, oh gosh, what is DSHS? I'm so sorry. Megan, if you want to throw that in the chat, so I'm saying the acronym right, it's failing me right now, but she says, adults and youth with intellectual and developmental disabilities can access crisis response that is able to address their needs. Absolutely, that is super important. I'm going to copy that and put that right in.
Yeah. Thank you. DSHS is the Department of Social and Health Services. DDA is the Developmental Disabilities Administration. And so I was thinking about how we would measure this, which could be about the surveys that someone talked about, but the outcome surveys after, satisfaction surveys for families afterward. I also wonder about the step up or step down of services. One of the things that I think happens now is that when, so I work primarily with youth, but when youth with developmental disabilities access the crisis response system, they sometimes, when the care isn't responsive to their needs, they end up in a higher level of service rather than it decreasing or de-escalating a situation. And so I wonder if there's a way to track whether, folks who are using, let's say like the youth mobile crisis, the MRSS, if they end up at the ER, then the MRSS response wasn't appropriate for their particular needs, versus if the MRSS comes out and then they get connected to a WISE team, for example, right? Or some other type of longer term care coordination, rather than accessing a higher level of acuity crisis support. So I don't know exactly how that would be measured, but that was one thought that I had about measuring whether or not the crisis response can address their needs. I have a second thing, but it looks like you have a question.
Yeah, I just want to make sure, because I want to get this down. So it sounds like the what this means in practice piece is that the individual gets the level of care that's appropriate to them. So not like the Goldilocks moment, right, where they get the right amount for the acuity they're experiencing. And then the measurement would be actually tracking the referrals.
Yeah.
And then maybe aligning that with the outcomes for them, so that we know, okay, they got this referral and got this outcome, and we could use that to judge whether or not it was the right level.
Yeah.
Okay.
Yeah, was actually responsive to their needs. Yeah, exactly. Something like that. And I don't know exactly how to say it for that measurement. The other barrier that I have witnessed is, and so again, I work with youth. I'm not sure if this happens in the adult system. It probably does, is that youth who need crisis stabilization or mental health treatment, who also have intellectual developmental disabilities, often cannot access services on the continuum of care if they need support for communication, or support with activities of daily living, or if they can't participate in, for example, like a group class. So the goal would be that people, in my world, I'm working with youth with IDD can access services at lower levels of acuity and have their needs for support with activities of daily living and communication not exclude them from programs such as like intensive outpatient programs, partial hospitalization programs, CLIP. Many of those programs exclude these youth because of those really ADA disability support needs, which is a huge barrier, a big, maybe outside of the scope of this, but I do think that this crisis system is connected to that.
Yes.
That as these youth are trying to access services, they keep having the doors closed, and that is how they're ending up in the ER, with overutilization of the ER, where they also are not necessarily being served.
Okay, I'm adding a comment here because it's an important, I'm adding a comment here so I make sure we capture your other point about this barrier. And then what I said here is, I'm just moving this comment so that we can see here. So people in crisis is what I meant. People in crisis who have intellectual or developmental disabilities can access care even if they have communication barriers or need support for activities of daily living, not leaving.
Yeah, I would say communication needs.
Communication needs, good.
Yeah.
Okay. And then I apologize. Did I miss, did you have a thought on the measurement there?
No, I don't. I feel like I'm still forming these thoughts about how.
That's fine.
Yeah.
That's
well,
fine.
you know, so part of what I've seen is the problem is that often the youth are told not to bother applying to these programs because people in the service system know that they will just be turned away. And so I do think that something like 988, who is providing referrals, has a place in tracking whether or not, you know, families, if they're referred to a service and then told don't bother applying because they're not going to accept you because you have these barriers, that could be measurable. It could be measurable if families actually applied for the services and got denied or excluded, but in practice they often don't apply because other people who work in the service system tell them not to bother applying. So there may be some culture shift that 988 could support happening in terms of getting folks to actually apply for services at these different levels. But I do think, you know, putting families through that process just to have them turned away is really painful.
Yeah.
And so, right, that, you know, so I think it's a pretty messy tangle that I'm not really sure how we address, but I would love, I feel like this group has a great potential for being able to look at those challenges.
Yeah. And actually, Megan, what you're talking about there raises that point that Puck made earlier about the experience of someone being thrown a lot of different services that, you know, like saying, well, try this.
Yeah.
And then they wind up getting turned away. So you're right that there's kind of, again, a Goldilocks moment where they're getting enough opportunity to get what they need without being overwhelmed by things that they're going to be turned away from. And in response to what you just said, Sherry Wiley is adding MRSS is designed with this is the mobile response and stabilization services. This is the one specifically for youth, is designed with a just go approach to divert from emergency department utilization for behavioral health needs, de-escalation, safety plan, and connect families to the right level of care available in their community. So it sounds like, at least with this model, you know, hopefully we're moving in the right direction. Sherry doesn't say anything specifically here about some of the barriers you raised with respect to intellectual and developmental disabilities, but I am reflecting on her point about the just go approach. So it sounds like, oh, and she says here they can support youth with intellectual and developmental disabilities. So that is great. I'm going to add that comment to here. Cassie, thank you for your patience.
Of course, I love having this conversation, so thank you for including me. I was just going to piggyback off of what Megan was saying regarding individuals with developmental delay or disability. My team is an alternative response team in Tacoma, so we respond with the fire department and law enforcement when there are calls for service. And one of the challenges that we've had with this specific population is that oftentimes when we arrive on scene, there's been some level of violence or behavioral combativeness that requires an outcome. but oftentimes there's an EDI plan that says do not take to the emergency department, or if you take to the emergency department, do not admit to the emergency department, require individual to sit in the waiting room, don't provide food, don't provide electronics, because it actually reinforces the behavior of taking them to these services. And so we've been trying to collaborate and connect if they have a case manager to talk about what we can do. Additionally, going to like a crisis stabilization unit, there's also oftentimes pushback from those services if they're familiar with the individual, because they will also identify that this is kind of, it's a behavior reinforcer. And so we come up against that challenge a lot, which has been tricky. And so I think if they are enrolled in services, having a very clear treatment plan or EDI plan that notes what are coping skills, what are strengths, what are resources that they do like. I think oftentimes our plans get stuck in this place of don't use these resources or you can't do this, rather than telling us what has been effective and what are appropriate strategies for each individual. And so I think that is something that would be really helpful for our teams, especially when we're going to like group homes or homes where there's 2 or 3 individuals living there with one care person. It would be really great to have some level of insight or information into what works for that individual.
Can I interrupt for one second, Cassie, just for clarification? So I wrote down individuals enrolled in services have a clear treatment plan. In other words, it's focused on what is effective and appropriate rather than what not to do. You said, and forgive me, this is my ignorance, you said an EDI plan. For those of us who don't know, what is that?
So it's a specific emergency department plan.
Okay.
So typically, if they utilize the emergency room frequently, their caseworker will create a plan with the social workers at the hospital to say your hospital agrees to work with the individual in this way. And there's usually team strategy meetings around it with a treatment planner, a case manager, anyone that has provided social work to that individual. So it really lists out what they believe is best, or what we can do to alter their behavior. So EDI plans are really helpful, but they're also tricky to navigate what other options are available. I was previously a DCR co-responder with the police department, and from my perspective, detainment or involuntary detention is it's very challenging because you want a person to have an opportunity to improve. And so often those services are not the best level of care for these individuals, as Megan talked about a little bit. And so we don't want people to get stuck within the system. It would be nice to have alternative services. And then the only other thought that I had, when there was the goal, the caller gets to make the decision whether or not they don't want a mobile outreach, not the call taker. I think because of protocol, that is sometimes tricky if the call taker is concerned about self-harm or some level of risk or danger. So my only thought is you could include a metric to have 988 identify how often they have to escalate the call to either the mobile outreach crisis team or 911. Because often if someone is calling and presenting with suicidal ideation, perhaps they have a plan or intent, they aren't really willing to engage in the phone call. The call taker might fear for their safety. And if that were the case, 911 can often get there more quickly than the crisis team. So I'm guessing they have a workflow around who they refer to when. But I'm guessing you could pull the data on how often it's telephonically triaged, and how often they have to escalate the call, even if the client is not interested in accepting those services.
Okay, so it sounds like both tracking how often they have to escalate and an additional measure of how often they're doing that when the client is saying that's not what they want. Great. Thank you for that, Cassie. All right, I have a note in the chat here. Oh, yeah, Jill clarified that back to Cassie's original comment, clear treatment / crisis plan. So I added that clarification in there. Other thoughts on this particular guiding principle? Should we maybe move on to the next one? I'm gonna take your silence there as we should move on to the next one, but please, if you think of something later on this, please don't hesitate to send me a chat and I'll go back and add it. Let's move down to the next one here. So this guiding principle, I thought this would be of particular value for this group to discuss. The crisis response system is centered in and informed by lived experience. So meaning, what does this mean in practice? Same questions. And measurement, how might we measure whether this is happening? So please take as long as you need to contemplate and then raise your hand or send me a chat to share your thoughts. Allie.
Hi. So I feel like so far we've done a really good job of focusing on the lived experience side of things. But I do feel like as this is implemented and we get away from this development stage, we need to continue to have lived experience a part of the refining and review process. So I'm not sure how we would what that'll look like, but I do believe that the lived experience should have a team that is continuing to be involved as we progress away from the development phase.
Okay, so the what is happening in practice is people with lived experience are involved in refining during implementation. Do I have that right?
They're kept involved even after implementation through the entire life of the program, basically.
Excellent. All right. I suppose a measure, did you have a specific thought on what a measure might be there?
I guess we could just measure that they're still there. Yeah, that's.
Yeah, I suppose like measure that lived experience is being consulted
On a regular basis.
On a regular basis, good. And then presumably, I'm just building off of what you said, that the system is being responsive to the feedback that they're providing.
Of course, yes.
Excellent. Thank you, Allie. Suram.
Hi, Jamie. So, one of the biggest pieces of feedback I've heard consistently about from lived experience is that we need more peers in the delivery of the services. So one of the things that I was thinking about is, and I don't know that this doesn't apply to the call necessarily, but it could also. But definitely when it comes to mobile response teams and the receiving centers, to kind of ensure that we have enough peers who are as part of the intake and interacting with the people. And so the way to measure it that I can think of is something along the lines of what percentage of mobile response teams and intake, the centers, stabilization centers have peers that are part of the intake and delivery of the services, right? What percentage of them are there, or in how many? Another way to think about it, I think about it, is how many cases was the first interaction the person in crisis had was with somebody who's a peer, right, as opposed to somebody who's a professional, because I think a lot of studies have shown that it's usually a lot more effective when they talk to with a peer than somebody who's kind of a authority figure or a professional. It usually works out better. So it's both a question of how many of the facilities have sufficient peers and how many of the interactions are initiated by peers.
Saw a couple of chats pop up, I think, in response. So we do have, Elena Perry, Department of Health says we do have peers and follow-up support roles with our 988 call centers right now. So this is certainly a measurable item. So that's encouraging, Saram. Thank you for bringing that up. Okay, I'll scroll back out again so you can see the guiding principle. I'm trying to kind of manage the scrolling so that you can see what I'm typing here as well. And please don't hesitate if you need me to move the screen around, I'm happy to do it. I'm going to respond to a chat here while you're all contemplating this one. Vashti.
I'm not really sure if this is the place for it, but as we're talking about peers, ensuring that the correct peer, so if it's a family peer, a youth peer, an adult peer, ensuring that that correct peer is out on the call and interacting with either the individual, the youth, the family, whatever. So there's not an adult peer going out to a family crisis that has no experience with their own families. Yeah.
Sounds like, Vashti, you're saying making sure peer's great, making sure that we're being appropriate and how we're sending peers out, that we're sending trained, experienced peers who are trained and experienced in the particular crisis they're addressing.
Correct.
Okay, great. Let me get that in here. Bear with me just a second, Lena. All right, Elena, your turn.
Yeah, these are all great. I put something in the chat, but I'll just read it out because I think something that I'm the lived experience subcommittee's DOH rep, and something that I hear Bipasha say often that I think is very helpful is we often think of people working in this system as being like separate from people with lived experience. I disclose often that I have personal lived experience with suicidal ideation and attempt, and I think many of our staff do. And so what we always do on the 988 program side when we recruit for new staff members is include a way for them to, count that lived experience of navigating the mental health crisis system, making sure that they know that that's not only welcome, but helpful in these roles. And so we can't require that our staff have, lived experience with mental health challenges or anything like that. But what we could look into in terms of metrics is, the percentage of staff at these state agencies who are working on 988 that anonymously, self-report those experiences or lived experience with navigating this system.
That's great, Elena. Thank you. And my own experience in doing this work with many professionals on this project and also in other states is that a lot of people who do this work do bring lived experience as well as professional experience. So thanks for raising that. Other thoughts? Sarah.
Hi. I'm not going to turn on my camera because I'm at home ill and no one wants to see that. But so I'm new to this particular meeting. I'm a sexual assault advocate and I run our prevention program in rural Grays Harbor. And a lot of my clients, particularly my youth clients, have a lot of interaction with mobile crisis and things like that. What I would think a measurement tool, and I'm not sure if I'm way off, with that lived experience is the hiring of, your peers, like the people who are working one-on-one or on calls with these folks, but as well the policy making. Making sure that these folks, it's great to have a master's degree or a bachelor's degree. It's great to have all of those things, but for example, you can't necessarily train someone on how to compartmentalize when they're dealing with trauma. And so you can get someone who's like, I'm a helper, I have a master's degree, but then, you know, they deal day in and day out with either suicidal ideation or sexual trauma, and they're like, nope, I'm out. I just spent all this money on this degree. But my point is, at all phases, from working with clients all the way up to policy making. And you know, I hate to see a room of legislators making a decision for me that have nothing to do with me. uh, I won't get on my feminist soapbox about it. I could, but I won't. So that to me is a metric, is how many people who are making policy for folks in crisis have that lived experience.
That is great. And I saw some nodding heads when you were speaking, Sarah. So I think that your thought is supported there. Bear with me just a second, Joel. I'm just going to get this in here. Okay. Thank you, Sarah. I hope you feel better. Joel.
I was trying to make a meaning, but I came up with the measurement before the meaning. But the meaning, I think, would be a continued committee like this that has the lived experience committee. That's one of the things that I first encountered with this, was going to the lived experience committee subcommittee, as it's called. And I think having that as an ongoing thing, or this committee and that subcommittee as an ongoing thing, would be very helpful in making sure that this principle is followed through. And then my brain, I forgot to write down the measurement part of it. The brain just blanked on that because I figured out the meaning and I lost the measurement. Oh, the measurement would be, I know from experience working in community mental health, we sometimes had a survey that was a paper survey that we put out for clients to fill out on their own, separate from their appointments with their clinicians or their case managers. And maybe even doing that and getting the all the community mental health agencies or other mental health areas to support this by giving out surveys, either a paper survey or an online survey that can let the people who are getting mental health support from them to bring in experiences of using the crisis line. So I don't know if that's a measurement or another meaning, but that was another thought I had.
I think I'm kind of leaning towards another meaning, like people
Yeah.
we're getting support from all parts of the system to gather lived experience.
Yeah. As I said that out loud, I agree with you, Jamie.
But I love it. I love it. So getting support from providers, distribute surveys. And that could maybe help too with some of that qualitative research that all of you were saying was really important in our previous.
Yeah. And I think it'll make people who feel uncomfortable trying to come to something like this feel comfortable speaking out and speaking up about their experiences without feeling that they're having to share who they are as a person, because that anonymity might make them feel more comfortable sharing what they felt and thought about it.
Yeah. Yeah.
So the measurement would probably be doing the surveys.
Yes.
For that one, at least.
Yeah, and I'm thinking your other comment about continuing CRIS type committee with a continuing lived experience subcommittee, we just need to know that it's happening. Okay. Great. Anything else on this one? We are making perfect timing because we have about, was it 18 minutes? No, 17 minutes left, so we will move on to the next one. But again, if anyone thinks of something they want to add here as we're talking about the next one, please don't hesitate to send me a chat and I'll make sure I get it in there. All right, last guiding principle assigned to us is the crisis response system is coordinated and collaborative across system and community partners. So please take a moment, as long as you need, to mull this one over, and then please share your thoughts on what does this mean in practice and how might we measure whether this is happening. Sure.
Yeah, hi. So I think the thought I had on this one is kind of feels similar to the first one where there was coordinated, so some overlap. But it feels like the metric of how many transitions that I think Fennec mentioned sounds like a good one here too, because a lot of it just feels like a good example of coordination is did you get to the right next step or not? Right? Or how many failed attempts before you got to the right next step? And so that's one aspect of it. The other aspect for me is kind of more the warm handoff principle is how I think about it, which is when you, I don't know, wherever it was, if it was whether you called or even if you're at a relief center, you're in a 24-hour and then 24-hour you have to get to a 2-week shelter, whatever, is that, is there both, is it smooth? Is it available? So it is, that's what to me coordinated means is, okay, I'm exiting out of the 24-hour stabilization center. I need 2 weeks. So there is a bed available for me for 2 weeks, right? So that's kind of, and if not, if I'm let go because there are no beds available, then my care is fallen through. So that's, I think, so it's really about, did they get the right next step is how the question is. And I think the way I think of measuring this is, if we know what the next step is documented in the system, then we can look to say, did the person get enrolled in that next step, right? If the next step is discharge, of course, yes, we know discharge is there, but really it's about how do we measure what the next step is.
So I heard you say individuals overall, what this means in practice is individuals in crisis get the right next step in the continuum of crisis care. And another way of saying that is handoffs from one service to another is smooth with no lags. And so one measurement you cited, and this is, and I agree with you that it overlaps, but I think that's fine. Hopefully we are measuring multiple things at once. But the measurement you proposed is how many transitions a person in crisis has to make before they get to the appropriate next step. Did I miss any measurements there, Shreya?
No, I mean, I feel like I'm missing a measurement, but I can't think of it. So, but I think you got what I said.
Okay, that's okay. We don't have to answer all these today. Like I said, we're going to be tackling measurements for at least the next, if not 2 more meetings, because this is a big topic. And like Puck said at the beginning, there's a lot of barriers and we need to address all of those. So don't worry. You don't have to come up with all the answers today. Sarah.
So kind of piggybacking off what he just said was referrals. Referrals are big for us. And really understanding what those referrals are. I'm in Grays Harbor. We're the only community-based sexual assault advocates. So understanding that, like, we're the community-based, we're the CAC, they're systems-based. So for example, on Fridays, we tend not to see clients. We have a big staff meeting, but we also invite different entities to lunch because if you feed them, they will come. Um, so inviting folks and just really, it's so much easier to do that warm handoff if you really know like who they are and what they do, what their barriers are and what their gaps are. So that I'm not just, because I also work at Crisis Line for work, is not just saying like, oh, let me Google a couple of phone numbers for you, but being like, hey, so I see Joel nodding his head, being like, hey, go talk to my friend Joel. This is what he does. He's going to be able to, do these things, and what he can't do, Jamie can do, or whatever. But I think COVID did not help us in the sense that we get really siloed in our jobs and we forget like, oh, when was the last time we met with that shelter? When was the last time we did that? So referrals are really big, and being able to potentially have meetings, like this, and being like, hey, we're getting some great referrals, or we're not getting anything at all.
I'm hearing, this is so great, Sarah, thank you. This is actually really good education for me. So providers who make referrals are educated about the services out there. And I think one of the even more important things you said is have relationships with those providers to facilitate better warm handoffs. And then did you have a thought on a measure there? And it's okay if you don't.
That's a tough one because, again, referrals, but we have so much confidentiality, and I'm just speaking from my scope. We have so much confidentiality that unless a client's like, yeah, you can go ahead and say that I'm getting services here, I can't tell anybody. I don't even acknowledge them first if I see them in a grocery store, because I don't want them to, I don't want to be like, hey, how you doing? And their friend is like, who's that? Oh, that's my sexual assault advocate. Way to jump scare you at the Safeway. So that's, metrics are really tough, but we can come to meetings like this and be able to say, without giving any identifiers, we're tracking the referrals that we're getting from these various providers, and this is where we're not getting referrals, and this is where we are. So I think it's maybe not a super tangible metric in the sense that we're inputting data into a computer that is shared, into some kind of thing that's shared, but being able to have the meetings and internally track where we're getting our referrals.
Sarah, I think we all think of outcomes, being able to measure outcomes as the gold standard, and it is, but it's not always possible. Like you said, there's barriers sometimes to measuring outcomes. So I'm taking what you're saying to me, and like we can also measure whether we're doing the things, and that's important too. Did I hear that right?
Yep.
Okay, awesome. Thank you for that. All right, I saw our 10-minute warning just a minute ago, but we are doing great. We're on number 3. Joel, next.
Mine was sort of what she was just talking about. That's why I was nodding my head at one point, because like, yes, this is what I'm talking about. There was a time, up until about 2 years ago, I was working at community mental health in the Everett, Washington area. And I remember we had a system that was connected to coordinate if a client is either called 911 or is taken to their emergency room. We as a clinician, if they are being seen at our agency, are informed of them going there. And it also included any history of them going there before and just a general understanding of what they went there for. And when I first started 10 years ago at that job, there was a system set up to where when we created a crisis plan with a client, that crisis plan also then went to the crisis line, and the crisis line was able to access that crisis plan when they were talking to them on the phone, if they were in community mental health. And I think that was one of the things that somehow it got disconnected along the way in that 10-year process that I was working in that agency. And I found that was the most collaborative and coordinated thing that could help someone. If they are in community mental health support and being seen by someone, and the person at the crisis line was able to access that crisis plan, it decreased the amount of need for that person to end up at an emergency room or a crisis bed, because they were able to use the proactive tool that they already made with their clinician So something like that, I think, would also be a great way to make sure that things are being coordinated and collaborative.
Joel,
Oh,
I have people in crisis have a crisis plan and are being served by people who have access to their crisis plan as the thing that we want to have happen.
that's a great way of putting it. Yeah.
Okay.
My long lecturing sentence.
No. That was really helpful. And I love getting the context of what you experienced. We know it can happen.
And it worked.
And it worked. Yes, we know
Yeah.
it worked, which is really inspiring. So I guess the measurement's very similar, which is the number or percent of people who are being served who have a crisis plan and that's being used in their.
Yeah.
Okay.
Yeah, I think that's the way. I didn't write that. I get a chance to write the measurement down, but that sounds about right. You're good at summarizing things, Jamie. Good job.
That is my job as a facilitator. I gotta summarize. So.
I do facilitating too, so it's that thing you gotta like. Okay, yeah.
Yes. Particularly when you're doing it on something where you're not an expert, but I'm learning so much from all of you. Okay, I'm just gonna get this down, and then Allie, I'll come to you as soon as I get this down. Okay, Allie, you're up.
I think that 988 needs to have, we need to have a centralized website or application where all of these services are listed and up-to-date, accurate information. I've had an experience before where I wasn't working in this field, and we had had a cold weather shelter in a building, and I get a call at 11:30 at night. There's a guy that was dropped off by the local ambulance service because they thought that we had a cold weather shelter there, and we hadn't had one in 5 years. But the local ambulance service thought that they were there. And so I just think that sometimes in this field, information gets out really slowly, right? Availability of beds, what services are offered, because sometimes a nonprofit has to close a program because it's not as effective or they don't have the staff for it. And so some way that a space that we can all collaboratively see and report accurate information about what services are being offered where, so that we can not have these gaps in referrals.
Allie, I think you would have a lot of CRIS committee members applauding that statement. That was actually a recommendation that they made in 2023 as well, that's really important. I do understand that it's not an insignificant thing to create and maintain, but there's so much interest in having something like that. So thank you so much for echoing that. Swearum. Oh, you're on mute.
Sorry. So I was just gonna say plus 100 on what Ali said. So that's one thing, just to the resource directory, 100%. I think that's important. Another thing I was trying to think about is, since we're talking about community partners here, to say how well funded are the community mental health agencies? And then the metric obviously would be measuring, if you were to ask them, what percentage of the funding that they need do they actually get, right? Then, that would be a good way to maybe measure how well are we doing, because I would imagine we're doing pretty poorly at this point. And when I say that, is the government funding, because they all try to be creative in raising money. So really, this is a question of, is the system, how much is the system funding them for the services that they provide?
Awesome. And I just saw a comment that you made a little while ago. I'm going to stop and look at the comments here. A metric to measure lags in handoff would be the wait time before you can receive the service. For example, if you have to wait 3 months to see a therapist. Yes, absolutely. I'm putting that in here. All right. Another comment in here. This one's from Megan Hopkins. I don't know how to state this for the structure that you have. That's okay. That's why I have those little comments. We can add that there. I'm thinking about collaboration with Kids Mental Health Washington, which is also working to coordinate and collaborate across system and community partners. And there's a link here that I'm going to share with all of you. The regional Kids Mental Health Collaborative Washington teams are keeping updated resource hubs for hyper-local information regarding mental and behavioral health services for school-age youth. So going back to this idea of a centralized website that Allie raised. They also have multidisciplinary team meetings and steering committees that bring together community and systems partners to address regional gaps and opportunities in the service system and to serve families directly by helping them navigate the system. Well, that just sounds amazing. I'm going to put that over here on what does this mean in practice. And I'm going to add the acronym so we don't lose that. And I promise y'all, I will clean this up later so that it accurately captures everything that we said today. And I'm going to share this link that Megan provided in the chat, so you all have it. Okay, here's the link to this collaborative that Megan's comment was talking about. All right, I think we have one more minute here. Anything else anyone wants to add in our last minute together? I can't believe an hour went by. That went so fast. I'm just going to scroll out so y'all can see your work. I'm pretty excited about this. Look at that. We got some really good ideas, I think, for what we want to see and the measurements. And the next step here, and I'll talk about this with the larger group, but the next step in here is to synthesize all of this, because as I think Saran pointed out in his first comment in this section, there is some overlap across all these guiding principles, which is actually, I think, a desirable thing. So we're going to synthesize all of this and then maybe continue working on this. And it looks like the breakout rooms are breaking up now. And so we'll see our CRIS members back in the main room momentarily. I will close the whiteboard here. All right, welcome back. I hope you had good discussions in your breakout rooms. We'll give folks another minute. Looks like people are still traveling from breakout to main room. Okay, I will say we had a great discussion in the main room here with the community. Hi, Puck. Great discussion in the main room with the community, and I am definitely going to want you all to get a chance to take a look at their ideas, because I think that can really inform your thinking about these metrics. So now's our chance to share what you talked about. And just as a reminder, we have 10 guiding principles. Each breakout room, we worked on one guiding principle together, and then each breakout room took 3 guiding principles, and we in the main room, I chose 3 that I thought would be of particular interest and would be particularly beneficial to get the point of view of the community. We worked on 3 in here too. I want to hear from you now about what you talked about in your rooms. And again, no need to give me share every sticky note. I think what I'd love to hear from you, and hopefully everybody else would love to hear from you, is what were some of the big takeaways from your conversation? What did you walk away really like thinking about and thinking this is important to note? And I'm going to start with breakout room 1, which I think was Michael's breakout room. Michael, did you get a volunteer to present from your room?
Darcy volunteered, and I said that I thought you would share the board, so
I will, yes,
so that they can see. Thank you.
Darcy, you are a rock star. Let me get that board up so that you can talk us through it. Okay, I'm going to scroll in so everyone can see. All right, Darcy, fire away. We'll start with the first one.
Okay, so we really we had a great conversation about this particular guiding principle, and some themes with all 3 of the ones we talked about related to the workforce and the need to have appropriate training, and that we have people who look like and have experiences like the people being served. When we were thinking about how we might measure some of that, we looked at some basics like the demographics of the workforce compared to the people being served, and really looking at where are lived experience people part of the team or part of the feedback mechanism. We also talked a lot about, you know, a good, strong, and consistent collaboration between 988 and 911, and making sure that the experience from both response systems still, you know, has the person in crisis having that welcoming response. Okay.
All right. So before we move on, other CRIS committee members who were not in this room, does anything stand out for you from what Darcy just said? Darcy, I'll make the point while they're thinking about their answer to that, actually in the main room, an issue, or when we were talking about lived experience and centering on lived experience, we also talked about measures of workforce who are peers who have had lived experience themselves. So there was some nice overlap with what you all talked about in the room, which is what we always hope for. All right, looks like we can move on, but CRIS committee members, if you have anything you want to add to this, please throw it in the chat and I will bring it up. All right.
For the next one that we talked about, again, we talked about training and making, you know, and also that people are compensated to participate in the training, that we had the ability to track the participation and outcome of the trainings. We also talked about the need for the crisis system to be aware that it has current institutional racism built into it, and how can we mitigate that, and some ongoing systems to monitor improvements in that area.
May I ask quickly what the red circles are about? Were those like the standout things that you wanted to
Yeah, those are the things that where we saw kind of themes across all three of these principles.
Nice. So you all did a little extra work, a little synthesis in there. That's good. All right. Any response from the CRIS committee members? I know you're probably digesting, so if you don't have anything to respond at this point, that's okay. Okay, let's keep going then. I'm
Okay.
the next one.
And then the last one that we talked about, and this was another theme across the three, that our system needs to be able to adapt to feedback, and that feedback is obtained in many different ways, including processes in place to get feedback from people who didn't have a good experience, who maybe had a negative outcome, maybe wound up in jail, in an ED. Are there ways that could, you know, the system could have responded differently to have a different outcome? And that we have good systems in place to collect information with clear expectation about how that information is going to be used. So we're not just asking for information's sake. We also talked about making sure that we have people with lived experiences at all points of the crisis system as part of the staff, so that they're employed, and not expecting them to be volunteers for their time.
Again, some really nice consistency with the conversation in the main room, Darcy, in two particular places around having people with lived experience involved continuously, so well through implementation and throughout the life of the system, and that the system is responsive to their feedback. So very nice consistency with what you all talked about, and a lot of interest in having opportunities for providing user feedback, and that the system can be responsive to that. So I'm just really pleased to see that level overlap. All right, so other folks in the room, did Darcy do a great job summarizing? Is there anything else that you want to make sure we call out here from your room, from being in that room?
I think that thing of making sure that we're supporting those folks with lived experience who are in the workforce, and that we're not making them like a hinge point that's gonna get pressure to kind of pretend that everything's okay.
Huck, I want to make sure I'm understanding, because I think that's a really, I mean, you've been in particular important advocate for bringing people with lived experience into this work and making sure that they're supported. If I'm hearing you correctly, it sounds like you're saying not expecting them because they're in the system to cover up or say that things are working just fine, that they also can be in a position of saying, here's where we need to make changes, or here's where people feel unsafe, or whatever. Do I have that right?
Yeah, I've spoken with several peers who are like the only person doing that work in their space, and they are often getting pressure from their institutions to just kind of hand wave things, and just really kind of feels like they're being tokenized. And I think that that's a bad habit we can fall into.
Thank you for that. All right, well, thank you so much, Darcy, Puck, all of room one. That was a great overview. I'm gonna open up the whiteboard for Nicola's room. And Nicola, was there a volunteer from your room to present?
Yes, we have Kristen Wells, who kindly volunteered to present our first guiding principle, and Anna, who agreed to present our next guiding principle.
Okay, Kristen, take it away. Oops, I'm sorry, I pulled up the wrong room. My apologies. This is not your room. Bear with me just a second. Here we go, Nicola. All right, I'm just going to scroll in here. Okay, and please just direct me around the board if you need me to move places.
Yeah, we had a lot of ideas for this first one about people in crisis experiencing person and family-centered care. A lot of the big ideas were about letting the person or the family in crisis define what the crisis was, what means a successful resolution, whether they are happy with what happened. We talked about advanced directives as well, and there was a little bit of discussion about culturally responsive practice and a mention of culturally active practice, but we need to get some clarity on the difference there. And then for measurement of this guiding principle, we talked a lot about customer satisfaction surveys, documentation that includes the client's definition of whether the resolution was a good one, quotes from the client or the family, and then checking things like, were people asked about an advanced directive? Was a follow-up call made up to that person or family afterwards to follow up with them about whether they are happy with how their crisis was handled?
All right, Kristen, this is great. There's so much good content here. And again, I just want to call out some overlap, since you all didn't get to see the great discussion in the main room, although it is recorded so you can watch it, that there is some overlap here about that, for example, that crisis resolution is defined by the individual in crisis and or the family, and some other thoughts on how we get that qualitative feedback from people in crisis so that we can measure whether or not we're really centering around them and meeting their needs. So thank you for that. And then I heard Anna's doing the second one. Is that right? I'll pause there. Actually, I forgot to ask. Any response from other CRIS committee members to what you're seeing on this particular board? Okay, I'm going to move on to Anna, who's going to present the second guiding principle here. Anna.
I swear there was a lot more sticky notes on this section.
I am not understanding. I felt like we had a lot more here as well.
Yeah, so.
Is it this one down here maybe, or?
No, it's the
No, we
one.
had more on our second.
Okay, we'll figure it out. Anna, do you feel like you have enough to go on, or do you feel like
Sure, I can do that. Let me just zoom in on that. Okay, so so there's all, there were a lot of sticky notes regarding, the systems communicating with each other, and So we've got like the partners need to trust each other and not, it's not a competition for limited resources. And so we really need to keep the focus on care of the individual in crisis, and you know, the partners need to communicate and trust each other rather than compete. All aspects of the system communicate with each other on the care that they give to the person in crisis. So there's no care that is repetitive or that is contradictory. Regular crisis partners meet on a regular basis. I think that would be probably regular regional crisis partners meet on a regular basis and have a regional crisis plan. Information is shared between system partners. I do know that one of the sticky notes on here was about communicating in real time instead of delayed information, because in a crisis, every minute counts. And partners need to be in agreement on how best to keep clients, how best to help clients to keep them away from the criminal justice system and hospital situations, as well as emergency departments. And then the measurements, regular interagency reports are created. And then let me zoom in on that other one. Feedback processes for partners and agencies for when coordination did not work well, specific dates, times involved, providers, King County Care Coordination Concern Forums. And so that's what I can see for now.
If I'm going to venture a guess, you know, tech can be really our friend and our foe sometimes, is that some of those sticky notes are hidden behind this board. So I'll do a little forensics and see if I can pull those out. But the good news is we have the recording. So worst case, we'll make sure that what we see in the recording, we actually get on the board. But thank you for winging it, Anna. I know that's not easy. And was there someone to present the third one, Nicola, or is that one going to be you?
That will be me. I'm going to
Okay.
just give a brief overview. So some of the key themes here are really recognizing and honoring tribal practices and recognizing differences among tribes, as well as ensuring that government to government processes are followed, and including a regular review of those processes. I think ways to measure whether this is happening, a couple of ideas here are regularly asking the tribes whether they feel these processes match their understanding and expectations, making sure we have tribal voices for lived experience and feedback, and reviewing the government to government processes timelines, that they are met and that those processes are signed off. So.
Okay, right on. Thank you for that. So and I'll ask this question for both these two guiding principles. Other CRIS committee members, any feedback on either of these? The coordinated one, the coordinated and collaborative system that Anna mentioned, and the honoring tribal government to government processes?
I did just want to highlight that one of them that I wrote was including like a case study, like where of not just of did we follow them, but how did we follow? How did we know we followed those processes? So that including references of like, oh, well, according to this is why we chose to make this decision this way.
Dylan,
oh, and this is Dylan from ACRS, by the way.
Was that for the tribal?
Yeah.
Okay, great. And I just want to reflect a little bit. The main room also talked about this coordinated and collaborative system. And they had some really nice ideas for how we have providers who are making referrals have education about and relationships with the places they're making referrals to really make those warm handoffs effective. And also an echo of a CRIS recommendation from 2023 about having some kind of centralized place to capture all of the services and keep it up to date. And we actually learned about a collaborative that I can share in the chat with you again, from one of Megan Hopkins with DSHS that is actually doing that on a micro level. So I'm going to put that in the chat for everyone because I think it's a great resource. And I'm going to close this. Just everyone, so you know, I know you probably saw the time. It's 3:52. We still don't have any signups for public comment, so I'm just going to keep carrying on with our report out. And I'm going to move on to Liz Arjun's room.
Great. Kashi is going to report out for our group.
Okay, let me pop that up. Thank you, Kashi. Let me get you in to a Zoom here.
Perfect. So our top guiding principle was that people in crisis experience care responsive to age, culture, gender, sexual orientation, people with disabilities, geographic location, and language and other needs. So there's lots of ways that that would look in practice. Sort of tracking with what others have said is that people feel heard and supported. They experience not only in their experience with the 988 system, whether that's call, text, or chat, that's responsive to their needs as an individual, but also that they get referred to resources that are relevant to them. So we had a conversation around the difference between sort of process measures versus outcome measures, because a lot of the things we were originally articulating could be measured for this were the number of trainings you can have call takers take, or the number of resource databases you can build to make sure people know what's available. But realistically, you actually have to know if people have a good experience with the system itself. And so whether that's client experience surveys or satisfaction surveys, we want to know if people actually experience care that feels responsive to their needs and to their identities. So we had a conversation about that feedback loop that I think Group 1 also mentioned as part of their care.
And I'll just add before we move on, I know we're running out of time, but I will just add that this is very consistent with what was talked about in the main room in response to this question. So community members also echo many of the things on here, including that user feedback piece. So thank you for that, Kashi. I'll scroll down to the next one.
Thank you, Jamie. And the second one is on technology. So the crisis response system empowered by technology that's accessible to all. So we had a great conversation both about how to be responsive to the diversity of how people utilize the crisis system, whether that's call, text, or chat, whether that's in verbal language other than English, or whether that's for clients who are deaf or hard of hearing or blind, and how people use technology. And so had some metrics about callers and chatters and texters. And one of the things we said in practicality is that we actually want the system not to look different depending on how you access it. You should still get the same experience and the same connection to care. And then we had a conversation about the technology platform being accessible to all is about the caller, but it's also about the system and how the system is connected so that it's accessible and serving the person in crisis well. So are the platforms accessible within systems and between system players, so that it makes it easier on the person sort of trying to access that. We had a conversation about how this might connect to social determinants of health, referral sources and bed registries and other resources that can make the system more visible to the provider community, as well as making sure that the way that people utilize the system is accessible to everybody.
And this feels like a particularly timely conversation given all the work that the state's doing on the tech platform. So thank you for that. CRIS committee members, anything to add to or any thoughts you have to add to what Kashi just shared on this one? All right, we have 4 minutes left, so I'm going to take us along to the next one.
Okay, I'll be quick on this one. We talked about sustainable and equitable financing of the crisis system, which started with a conversation about paying our workforce, high quality workforce, and retaining them and training them. And then a lot about how we want a dependable, diverse, sustainable, ongoing funding source for the whole system, and making sure that's part of the plan for this system is a way that this can be funded in perpetuity in ways that are sustainable, and that there are multiple funding streams so that those who should be contributing to the system financially are doing. The other thing we talked about here was that really leaning into the word system as a part of this guiding principle, that the funding of the system is responsive to the needs of the people using it. So if we identify, for example, that there are lots of callers who want a mobile response up in Bellingham, but we don't have a mobile team up in Bellingham, this should be a way that the system should be able to learn in terms of continuous process improvement about where we need to put additional fiscal resource to create a system that is actually responsive to what people are asking for. So we talked about how we want this in practice to look like the needs and experiences of callers contribute to continuous process improvement, so that we can finance a system that actually has all the pieces people want.
Oh, I love that, Kashi. That's really great. And this did also come up in the main room, in particular with respect to community mental health services, but in general that the system is providing adequate levels of services, or sorry, adequate levels of funding to the individual services that we need. And I see a comment from Puck. At some point before this came up, what I would have referred them to if it existed kind of thing for phone operators. Yes.
Yes, like using that data to say, here's where we could put more money in the system and it would build us a better system.
Exactly. And you could see where there's deserts, for example, like service deserts. Okay, that's excellent. Everyone, I just love what you did here. Thank you so much for the great work on this exercise. Next steps here, we're going to, as you've noticed, there was a lot of overlap, which is great. I said this a few times in the main room. That's actually good. We want measures that can help us know if we're meeting multiple guiding principles. So we're going to do some cleaning up and synthesis of all of this, so that this can be a tool that we can reference back. But this feedback that you've provided, we're going to use to inform starting to really dig into what performance metrics are possible, what we should aim for. I am going to pause there. Nicola, are there any action items and next steps to run through with our CRIS members?
I think we are all set. We had a few action items coming out of the updates and questions for agencies, so we can follow up on those, but otherwise we're good. Okay,
yeah, I recall there was something on timing of getting community feedback or stakeholder feedback on the tech platform, and an answer to a question that Tisha's going to circle back with us on. It is 4 o'clock. Thank you, everyone. I know it was a lot of brain power on this meeting today. A particularly big thank you to Kristen Wells, who had a big job in her first meeting as a CRIS committee member. And to Ashley for her beautiful and powerful story, and to all of the CRIS committee members for all of your contributions, to the facilitators for facilitating such nice breakouts, and most especially to our community members and our community of people with lived experience who are giving up time in their days and emotional and brain labor here to help us make a better system that is responsive to all. I wish everyone good health. I look forward to seeing you in a month and in 2 months in real life. Everyone take care. Have a good rest of your day. Okay.